Good afternoon and welcome everyone to today's 60-minute refresher session, Preventing Healthcare-Associated Infections, Surgical Site Infections. So this session is brought to you by Project Firstline Rhode Island under the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health in partnership with the CDC. I'd like to thank you all for joining us and thank you for the vital role that you play in healthcare. At this time, I'd like to direct your attention to the chat. You'll find a link to our pre-session survey. If you haven't filled that out already, please go ahead and do so. That will close shortly into the webinar today. At this time, I'd like to ask Dr. Alexis Kearney to come on and introduce herself.
Good afternoon, everyone. Super excited to have you all here. We've got a great hour planned for you. We'll be in the background, so please feel free to reach out if anything comes up.
Thanks, Dr. Kearney. My name is Stephanie Doyle. I'm an infection prevention training liaison for Project Firstline Rhode Island and a consultant public health nurse at the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. I've been practicing healthcare for over 20 years, worked in many different roles. I have an array of different nursing experience, which has led me to my practice in public health and education. Today, I'll be your host and presenter. I hope to raise awareness and help you understand the importance of infection control and prevention to help keep our patients, ourselves, and our colleagues safe. And before we begin, again, I'd like to direct your attention to the chat and introduce Abby Anderson, who is our Project Firstline Rhode Island Project Assistant. Good afternoon, Abby. And we have the whole team behind the scenes in support of this webinar today. Abby will be posting information for you throughout the webinar via chat. And now if you'd like to take a minute to introduce yourselves in the chat box, tell us your name, your organization, where you're coming in from, and feel free to add your email if you'd like to be added to our distribution list. So glad to meet everyone. Everyone is muted. If you have any questions, feel free to throw them in the chat or the Q&A box. We will have some time at the end to answer any of your questions, and if we can't get to all of them, we will certainly email you the answers to those questions. And the chat box is open for discussion questions as we go through the webinar. So I would like to review our continuing education reminders, continuing education criteria for those who are attending and would like to receive continuing nursing education credit. So this session is approved as one contact hour. This nursing continuing professional development activity is approved by the Northeast Multi-State Division Education Unit and accredited approver by the American Nurses Credentialing Center Commission on Accreditation. To receive your certificate of training, you will need to complete the following: pre-session survey, attend the webinar, and the post-session survey. If you would like to receive CNE credit, you will need to complete all three of the previous requirements and a post-session quiz, and that will be emailed to you with the post-session survey. And if you have any questions regarding the CNE process, we'll be happy to answer those as well. So on our agenda for today, we've done our welcome and introductions. We will review learning objectives. We'll talk a little bit about healthcare-associated infections. We're going to define surgical site infection. We'll talk about infection control actions to prevent SSI. We will do some knowledge checks and review a case scenario, review key takeaways. We'll ask for your feedback, and we'll have some time for questions at the end. So our learning objectives today, we'll learn the implications of SSI for patients in healthcare, or surgical site infections, which I will refer to as SSI throughout the presentation, identify the different types of SSI, learn common causes of SSI, recognize the signs and symptoms, understand the evidence-based infection control actions recommended to prevent SSI. So first, we'll review a little bit about healthcare-associated infections. Before we narrow down specifically to SSI, I'd like to talk briefly about HAIs, or healthcare-associated infections. So what are HAIs? HAIs are infections that patients get while or soon after receiving healthcare. No matter where you are, hospital, long-term care facility, outpatient surgery center, dialysis center, doctor's office, you are at risk for these infections. To develop an infection while receiving these services, germs must somehow enter your body. Germs often spread from unclean surfaces to the hands of healthcare workers, patients, or visitors. And some of these germs are even resistant to some medications. They are a serious threat to health and safety of patients receiving healthcare. According to the CDC, 1 in 31 hospitalized patients will get an infection because of the care that they receive. An estimated 75,000 patients will die each year from healthcare-associated infections. Luckily, these infections are often preventable through infection control practices that we will learn more about today. And preventing HAIs is a top priority for the CDC and its partners. So HAIs are a subset of infectious diseases acquired in a healthcare facility. To be considered healthcare associated, the infection cannot be present at admission. Rather, it must develop at least 48 hours after admission. These infections can lead to serious problems like sepsis and even death. And as mentioned, they can be caused by multi-drug resistant organisms and may be acquired via invasive procedures, excessive or improper antibiotic use, and not following infection control and prevention procedures can also contribute to healthcare-associated infections. As mentioned, many HAIs are preventable through guidance issued by national public health institutes such as the CDC. So today, our HAI of concern, surgical procedures associated with surgical procedures of surgical site infections. So a little bit more about SSIs in general. SSI remains a substantial cause of morbidity, prolonged hospitalization, and mortality. It is reported SSI accounts for 20% of HAIs and is associated to a 2 to 11-fold increase in the risk of mortality, with 75% of SSI-associated deaths directly attributed to the SSI. SSI is the costliest HAI type with an estimated annual cost of $3.3 billion and extends hospital length of stay by 9.7 days, with cost of hospitalization increased by more than $20,000 per admission. Previous reports have noted that approximately half of SSIs may be preventable by implementing evidence-based strategies. In 2017, the CDC released updated guidelines for the prevention of SSI after surgical procedures and recommends the integration of the guidelines for improvement in quality metrics, reportable outcomes, and patient safety. So SSI is defined as an infection related to an operative procedure that occurs at or near the surgical incision within 30 to 90 days of the procedure, depending on the type of procedure. Most surgical sites can be prevented if appropriate strategies are implemented. These infections are typically caused when bacteria from the patient's skin flora are inoculated into the surgical site at the time of surgery. Development of an infection depends on various factors such as the health of the patient's immune system, presence of foreign material, degree of bacterial wound contamination, and use of antibiotics prior to surgery. So what are some signs and symptoms that your patient may present with if they acquire a surgical site infection? So fever, pus, redness, swelling, pain, and warmth are signs and symptoms to look out for when assessing for a wound infection. Certain surgical sites, such as the abdomen or deep within the body, are more prone to serious complications such as wound dehiscence or opening of the surgical wound, formation of an abscess or collection of pus, tissue death, loss of limb or organ. And SSI can also lead to bacteria in the bloodstream, sepsis, which is a systemic inflammatory response to infection, septic shock, or even death. So the treatment for SSI generally includes antibiotics. Sometimes patients need another procedure or surgery to treat SSI. SSIs may require specialized wound care, which may include the use of a wound vac device. So now we'll get into recognizing infection risks. So what are some risk factors that we look at when we're assessing our patient for risk of surgical site infection? The risk can be affected by the patient, the surgical team practices, the operating room environment, and the surgical technique. So the patient may have some modifiable or non-modifiable risk factors. Modifiable risk factors include nutrition, smoking status, obesity, glucose control, or colonization with any multi-drug resistant organisms. Non-modifiable risk factors include age, sex, immunosuppression, comorbidities that the patient may have. Surgical team practices such as implementation of surgical hand scrubs, antisepsis at the surgical site, and antimicrobial selection. Risk factors in the operative environment include cleaning and disinfection of the operating room or operating surgical equipment, management of traffic in the operative environment, personal protective equipment use and asepsis, and air handling. And the surgical technique includes careful handling of tissue, duration of the case, type of surgery, and location of the surgery. So when thinking about the surgical process, let's think about where you may see the possibility of germ spread. First, we'll talk about the reservoir, which is the source of the germ. This is the place where the germ lives and multiplies, like an infected person, contaminated surface, or environment. So first, germs live on skin and can spread by the pathway touch. Skin carries many germs and spreads them easily. Skin, especially the hands, interact with the environment daily. Many germs live and grow in healthy skin and normally do not cause harm, but some of those germs can be harmful to vulnerable patients, especially when the skin is broken during a surgical procedure. Germs also live in the gut and can spread by the pathway touch. The intestines are filled with very large numbers of bacteria and yeasts, many of them helpful and don't cause problems in healthy people, but under certain circumstances can be dangerous to those with weakened immune systems. Because these germs live in the intestines, they are in our stool, and these germs travel easily in stool from the gut to other places. Germs live in blood. Blood is a very good place for germs to grow. If you see blood outside the body, you should consider it potentially infectious. If blood gets into the environment, like on linens or a device, those germs are likely to grow and multiply and can spread. And finally, germs live on surfaces. Germs can live in water, dry surfaces, dirt and dust, and on medical equipment. So let's think of the surgical process as a whole. How many opportunities can you think of that exist for germs to spread, and how can we prevent germ spread from happening and causing illness? Surgical site infections can spread through various pathways, primarily via direct contact with contaminated surgical staff or instruments. Bacteria may be breathed in or out from the operating room environment. The patient's own skin flora entering the surgical room during the procedure essentially is the most common pathway. Direct contact with contaminated surfaces or objects breathed in or out, and migrations from the patient's own skin. So some common organisms for SSI, as you see here, the CDC guidelines for the prevention of SSI emphasize the importance of good patient preparation, aseptic practice, and attention to surgical technique. Antimicrobial prophylaxis is also indicated in specific circumstances. So the causative pathogens depend on the type of surgery. They can be categorized by endogenous or exogenous. Endogenous is growing or originating from within an organism, and exogenous originating from an outside source. So opening the skin to the lower abdomen during urologic procedures and gynecologic procedures can serve as a reservoir for gram-negative bacilli such as Pseudomonas. E. coli or Enterococcus species are common if there is entry into the GI, GU, or respiratory tracts, and some SSI may be from resistant species of these organisms. And when a skin is incised, underlying tissue is exposed to overlying skin flora. Most typically, aerobic gram-positive cocci, such as Staphylococcus, serve as the contaminant, with resistant pathogens such as MRSA, methicillin-resistant Staph aureus, representing an increasing proportion of such infection in recent years. So wound classification, warning, these images can be graphic, so if you need to look away, feel free to do so. Surgical wounds are classified by degree of contaminants present. Classification allows for appropriate risk stratification for development of complications and assists with guiding appropriate treatment. Wound classification is a system developed by the National Academy of Sciences and the National Research Council, is considered a strong predicting factor for subsequent development of SSI. So surgical wounds can be classified into one of four categories. These categories depend on how contaminated or clean the wound is, the risk of infection, and where the wound is located on the body. So clean is an incision in which no inflammation is encountered in a surgical procedure without a break in sterile technique and during which the respiratory, GI, or GU tracts are not entered. Clean contaminated, no evidence of infection at the time of surgery, an incision through which the respiratory, GI, or GU tract is entered under controlled conditions, but with no contamination encountered. Contaminated is an incision undertaken during an operation in which there is major break in sterile technique or gross spillage from the GI tract, or an incision in which acute inflammation is encountered. Examples would be trauma or bowel resection. And dirty, an incision undertaken during an operation in which the viscera are perforated or when acute inflammation is encountered during the operation, for example, emergency surgery. Infection is already present at the time of surgery, such as a diabetic foot ulcer or peritonitis. There is a near linear relationship of escalating wound classification and subsequent surgical site infection, and that has been demonstrated in the literature, with as low as 1.3% of clean wounds and as many as 40% of dirty cases are complicated by SSI. Surgical site infections are also classified by the location of the infection, superficial or incisional, deep, or organ or space. And I'll get into those in a little more detail here. So superficial incisional SSI, skin or subcutaneous tissue is involved. It occurs within 30 days postoperatively and must fulfill one of the following additional criteria. Have infectious or purulent drainage from the incision with or without laboratory testing or culture, isolated organisms from aseptically obtained fluid or tissue culture and incision, at least one sign or symptom of clinical infection, including pain, redness, swelling, warmth, and the superficial incision is deliberately opened by a surgeon unless culture is negative. Diagnosis of a superficial incisional SSI by a surgeon or attending physician. And that occurs at the first level. The deep incisional surgical site infection. This infection occurs beneath the incision area in muscle and the tissues surrounding the muscles. It involves deep, soft tissues such as fascia or muscle within the incision, occurs within 30 days postoperatively without implantation, occurs within 1 year if an implant is in place. An infection appears to be directly related to the surgical procedure and must fulfill one of the following additional criteria. Purulent or infectious drainage from the incision, but not from the organ space of the site. Dehiscence or deliberate opening by the surgeon from a deep incision when the patient has at least one of the following signs or symptoms of clinical infection. Fever greater than 100.4, localized pain or swelling, unless culture is negative. Abscess or other evidence of infection involving the deep incision is found during exam of incision, reoperation, or pathological or radiologic exam. A diagnosis of a deep incisional SSI by a surgeon or attending physician. An organ or space SSI involves any part of the anatomy other than the incision, occurs within 30 days postoperatively without implant, occurs within 1 year if implant is in place, and infection appears to be directly related to surgical procedure. It must fulfill one of the following: purulence from a drain that was placed via incision into the organ space, isolated organisms from fluid obtained or tissue from the organ space, abscess or other evidence of infection involving the deep incision is found during exam, diagnosis of an organ space SSI by a surgeon or attending physician. If both superficial and deep layers are involved, or if organ space SSI drains through incision. Classification will be deep incision. All right, that's a lot of information. Time for our first full question. So the 4 classifications of surgical wounds are A, clean, red, swollen, and contaminated. B, clean, contaminated, dirty. C, dirty, red, swollen, painful. D, none of the above. Thank you. Thanks for your participation. We have 71% answering B, clean, contaminated, and dirty, which is correct. Very good. Thank you so much. Now we'll be moving on to infection prevention and control actions. So CDC has released the 2023 National and State Healthcare Associated Infections HAI Progress Report. This report shows no change for colon surgery and an 8% increase in SSI for abdominal hysterectomy. So although progress has been made in preventing several important HAIs in acute care hospitals, which you can see compared to 2022, SSI remains an HAI of significant concern, which is why the infection control actions are especially important for surgical patients. And Abby does have a link to this page if anyone is interested in looking at that data. Very interesting. So after success with bundles for the prevention of other HAIs, such as ventilator-associated pneumonia and catheter-related bloodstream infections, the Institute for Healthcare Improvement, IHI, defined a care bundle as a straightforward set of 3 to 5 evidence-based practices that, when performed collectively, improve patient outcomes. So the concept of care bundles was introduced in 2001, and it's a set of practices, when implemented together, improve patient outcomes. So bundle approach to surgical site infections are implemented across the continuum of care, work best if used across disciplines, can be tailored to a specific specialty, and have been proven to reduce infection rates. Numerous factors before, during, and after surgery influence the patient's risk of SSI. Because the prevention of SSI is complex, bundles ensure compliance and improve patient safety. So many factors can contribute to the development of SSI. Care should be taken at each phase of the surgical process. Before surgery, the health of the patient should be optimal. At the time of surgery, factors such as managing personnel within the OR and the OR environment can affect infection risk. And after surgery, care of the surgical wound, including making sure healthcare personnel wash hands and wear appropriate PPE when changing any dressings. And after discharge, patient education and communication to all healthcare personnel involved in the care of the patient are key factors in prevention, which we'll get into in a little bit more detail coming up. So our next poll question: infection control actions for surgical site infections are only relevant in the intraoperative phase of the surgical process. True or false? So recommendation categories were categorized using the following standard system that reflects the level of supporting evidence or regulations. And these can be applied to our infection control actions that you may see in any care bundles that are used in your facility. So category 1A is a strong recommendation supported by high to moderate quality evidence suggesting net clinical benefits or harms. Category 1B, a strong recommendation supported by low quality evidence suggesting net clinical benefits or harms or an accepted practice. For example, aseptic technique supported by low to very low quality evidence. Category 1C, a strong recommendation required by state or federal regulation. Category 2, a weak recommendation supported by any quality evidence suggesting a trade-off between clinical benefits and harms. And no recommendation or unresolved issue, an issue for which there is low to very low quality evidence with uncertain trade-offs between the benefits and harms, or no published evidence on outcomes deemed critical to weighing the risk and benefits of a given intervention. So our SSI prevention strategy is across all phases of the operative journey. So no matter what area of healthcare you practice in, it is likely you've come into contact with a patient at any time in their surgical process. As we talk about the surgical process, let's think about what tools we have to prevent infection at each phase. So CDC has revised the 1999 article, Guidelines to Preventing SSI. Using these evidence-based practices and other proven strategies adapted by agencies who are experts in the care of the surgical patient, SSI can be greatly reduced. So have you encountered patients during their different phases of the surgical process? As we think about the process as a whole, each phase requires different evidence-based practices to prevent a surgical site infection. We'll now dive into each phase in a bit more detail. So we discussed earlier bundle approach to prevention, SSI. Every individual is unique, and each situation should be assessed in a manner that best reduces risk. It's important to have evidence-based practices that have been proven to be effective in place. Many different types of medicine perform surgeries for many different reasons. Each specialty will require certain interventions to reduce risk of SSI. Surgery requires breaking the skin barrier to create an incision, breaking our body's natural defenses. No matter where you meet your patient during the process, either preoperative, intraoperative, in rehab, your facility will have protocols in place to follow during care of the surgical patient. Strict adherence to protocol and communication can be key in providing the best care possible. Now we'll look at one patient's journey through the surgical process with our interventions focused on abdominal surgery. So let's meet our patient. Our patient is, let's call him Mr. P. Mr. P is a 58-year-old male. He has a history of Crohn's disease, obesity, alcohol use disorder, and nicotine dependence. He is prescribed an infused medication monthly for his Crohn's, which he receives as an outpatient. Recently, he has been experiencing frequent loose stools, including some bloody stools, increased abdominal pain, and bloating and urinary frequency. He has no history of prior surgery, but does have a history of MRSA, methicillin-resistant Staph aureus, and Meniere's. And the surgery team is recommending surgery for complications of Crohn's disease. So you're performing a perioperative interview with Mr. P. Based on the information above, what are some risks of SSI that you might identify, and some infection control actions you can take to assess for risk and prevent SSI for this patient? Go ahead and share some thoughts in the chat. See what you think there. What are some risks of SSI that you see for our patient, Mr. P? Obesity, alcohol use, history of MRSA. Yep. Yes, history of MRSA. Good, good. So Mr. P arrives for his preoperative appointment. He was screened for MRSA and found to be positive in the Meniere's. His blood work revealed an elevated white blood cell count and is reporting urinary frequency. His urinalysis is positive for UTI, urinary tract infection. He admits to the smoking and the drinking. And you review his medication list and find that he takes the biologic for his Crohn's disease that impairs his immune system. So what are some interventions that you may have for Mr. P prior to his surgery? So what are some interventions that you might recommend prior to Mr. P arriving for his surgery based on that assessment? Any ideas? Decolonization, very good. CHGF, yeah. Bathing, antiseptic bathing, reduced intake of alcohol, very good. Great. So some interventions occur as an outpatient. Some may occur immediately prior to surgery in the perioperative area. Based on your facility policy and risks identified, the team determines interventions you will use to prep the patient for the procedure. Some actions may occur in the weeks prior to surgery, and some may occur immediately prior to the procedure. Evidence suggests preoperative interventions are recommended to help reduce the risk of SSI. Bundle approaches, as we talked about earlier, include evidence-based approaches, which when used together have been proven to reduce the risk. This is a review of some high-level interventions that can be utilized as part of the preoperative care bundle. Remember to review your facility policy relative to the interventions the interdisciplinary team has established to reduce infection rates. Interventions may include the following at this phase of the process: identify modifiable risk factors, recommend or require mechanical bowel prep, administration of oral antibiotics for untreated infections, such as Mr. P has UTI, screening for colonization, and then treating any infections that are identified. Optimizing the health of the patient is key. Smoking cessation and stress reduction may be interventions that reduce the risk of SSI. Furthermore, in the preoperative phase, skin antisepsis at the surgical site, bathing with a recommended soap or cleaner, skin antisepsis application just prior to surgery, hair removal, not to shave the hair, but to clip the hair just prior to surgery in the procedure room if recommended, and antibiotic or antimicrobial prophylaxis are some preoperative interventions that can be implemented. All right, so you did mention some interventions there. Are there any other interventions that you can think of that would be relevant for Mr. P in the preoperative phase? I think we covered them all, so move on. So Mr. P arrives for his surgery. He's prepped and ready. Based on the complexity of his open abdominal surgery, the surgery will take about 4 to 5 hours. Mr. P will be admitted to the hospital for a few nights after and may require rehab. Surgery team will need to make sure optimal conditions exist in the operating room to reduce the risk of SSI for this high-risk patient. So let's look at some intraoperative practices related to the environment of care during Mr. P's surgery. So in the operating room, it's pertinent to think about proper ventilation, making sure the operative environment is properly ventilated, getting proper air exchange, minimizing traffic inside the OR, making sure that doors are closed with minimal opening, maintaining the patient's body temperature. Normothermia is the maintenance of a patient's core temperature at normal levels during surgery. It's important to prevent surgical site infections and complications due to hypothermia, and enables adequate immune functioning and perfusion to the surgical tissue, maintaining glycemic control, making sure it's everyone's responsibility to make sure that PPE is worn and effective, and if any breaches occur, they're reported immediately, and maintaining asepsis in the surgical environment. So let's name 3 modifiable risk factors that can be found in the OR. And how can these be modified to ensure best outcomes for Mr. P? Go ahead and see if we can name 3 modifiable risk factors that can be found in the OR. Anyone have any ideas? Ventilation, temperature control, PPE, room temperature, making sure the airflow is adequate, reducing traffic. Very good. And like I mentioned, it's everyone Everyone's responsibility to maintain sterile practices. Thank you. Proper hand hygiene, absolutely. Keep each other in check, making sure that practices are followed. Very good. Excellent. So Mr. P is now in the post-operative phase. He's admitted to a short-term rehab hospital after a 5-day stay in an acute care hospital intensive care unit and general surgical unit. He has a midline abdominal wound and ostomy with an ileostomy stoma and appliance. You observe slight redness and swelling near the incision and a small amount of thick yellow drainage staining the dressing. Now Mr. P is in the post-op phase. Let's look at some infection control actions we can take to reduce the risk of infection during this phase of the surgical process. So patient education helps to empower the patient to advocate for themselves, ensuring all healthcare personnel maintain infection prevention and control precautions when assessing the wound and performing any wound care activities. Also, patients should be aware of signs and symptoms that they may see if an infection occurs. Discharge planning. All healthcare personnel involved in the care of the patient should be aware of any wound care required, and the facility staff should be trained and confident in the care of the surgical patient. Recognizing and reporting signs of infection in the recovery phase can expedite treatment and inhibit further complications if infection is noted. Also, avoiding unnecessary antibiotic use, continued wound assessments either by the care team in the facility or at home, and maintaining wound asepsis are key infection control actions that can prevent infection. Following the surgeon's orders for incisional site care, such as keeping the wound covered and using proper PPE when handling dressings, can reduce the risk as well. So what are some post-op infection control actions that will help reduce the risk of infection at this phase of the process? Feel free to share in the chat if anyone wants to share some infection control actions that will help to reduce the risk of infection or complications of infection at this point of the process. Post-op antibiotics. And based on your assessment, including risk factors, do you think Mr. P may have a surgical site infection? If so, what type of surgical site infection fits the appearance of this wound? We can go back and look at the small amount of thick yellow drainage staining the dressing. Superficial or incisional? Good. All right, very good. Thank you for sharing in our scenario discussion. So in summary, as we follow Mr. P through his operative process, we learned how many factors can contribute to the development of surgical site infection. Through each stage, important infection control actions can be implemented using evidence-based bundle approaches. As frontline caregivers, it is our responsibility to maintain focus on patient safety and adhere to best practice to strive for the best outcomes, especially for our most vulnerable patients. So for our key takeaways, a surgical site infection is an infection in or near the part of the body where surgery took place. SSIs can often be treated with antibiotics, but may require additional medical care or surgical intervention. And using an evidence-based bundle approach to implement infection control actions at each phase of the surgical process can reduce the risk of SSI. Here are our resources and our social media. Feel free to follow us on all social media and sign up for our newsletter. And we have webinar recordings and webinars, live webinars you can sign up for on our website there. And if you'd like to enter your email to be added to our distribution list, that just includes a monthly newsletter and notifications of any live webinars that we have coming up. And Abby can share a link there in the chat if you'd like to visit our website. Here are our references for today's session. And just a reminder before we wrap up, a few requirements to receive your certificate of training. Please complete the post-session survey, which will be emailed to you following this webinar in the next 24 hours or so. And that will close in 1 week on April 14th by midnight. And then there's also a post-session quiz if you would like to receive continuing nursing educations for this 1 credit for this session today. And your certificate will be mailed on the 17th after completing all of the requirements mentioned there. Now, if you'd like to take a few seconds to fill out our end of session feedback poll, and then we'll go right into questions. All right, now I'll invite Dr. Kearney on. And I don't see any questions on the chat, but feel free if anyone wants to come on, we can unmute you. Or if you'd like to type your questions in the chat, feel free to do so. And if you think of anything after the session, please feel free to email us. We'd be happy to answer your questions via email as well.
Haven't seen any come through, Steph.
No, nothing. All right, well, thank you everyone for joining us today. I'm happy to see everyone and hope you enjoy the rest of your day and hope to see you in the future.